Well, welcome to the second hour of lecture today in our Urology COVID series. It's really my honor to be giving a lecture in this series, which was, started out of an effort to provide education for trainees in a time when they weren't getting other exposure because of the decreased clinical volume because of the COVID outbreak. So I've really been humbled by both the learners who are interested in continuing their education and participating in these lectures. We've had, 300 to 600 participants for each lecture, which is amazing. And a lot of people are viewing the lectures afterwards too. And we've had really an outpouring of interest from faculty members wanting to give lectures, which is great and really speaks to, our field as a whole and an interest in improving education for everyone. So I'm going to talk today on pelvic fracture urethral injuries. And this is really, I think, an overlap of two AUA guidelines, the Urotrauma guideline as well as the urethral stricture guideline. So we'll try to make this a guidelines-based approach. See, here we go. Okay, I don't have any financial disclosures. I do have a personal disclosure, which is that I do have 2 young kids and I'm working at home, so hopefully they don't make an appearance. But I saw this tweet the other day, which totally encapsulates my experience. And any residents who have worked with me, I think, have had this exact experience with me where my toddler has come in like asking me to wipe his bottom in the middle of a consult. So hopefully you don't see them. All right. I'm going to start by just trying to connect us all a little bit, because I know that while I can see that there are a lot of you can't see each other. So if you can, either scan the QR code or go to slido.com and put in the participant number, which is N408, and tell me where you're joining in from. All right, so Philadelphia, San Francisco, Buffalo, Rochester, Durham, Ottawa, Chennai, India, Ottawa. This is awesome. So I think what's so cool about this series is really that it does kind of connect us from a lot of places. And it's a way for us to, despite the social and physical distancing that we're doing, it's a way for us to feel connected as a community. So this is really cool to see where everyone's from. We have people from Hershey, Syracuse, Tampa, Milwaukee, Pittsburgh, Atlanta. So there's a big contingent from Philadelphia, Minneapolis, and Chicago, looks like. So that's great. All right, next, Saudi Arabia I saw too. We've had a lot of international participation, which is really cool to see as well. Mexico too. Cool. All right, next I'm just going to ask a question about what level of training you're at so I get a sense of where you guys are coming from. Residents are fast on the uptake. We have a few practicing urologists. We have some medical students, fellows, advanced practice providers, but mostly residents. All right, awesome. Okay. Next, I want to ask some questions just about the impact of COVID on your experiences as trainees. How much has this impacted your clinical or outpatient volume? Oops, sorry, I ended that a little early. Okay, so it looks like for most people, it's really a significant decrease in volume. Only a few people have had no change or an increase in volume. Okay, what about your operative case volume? Big decrease in volume. That's not surprising. In our own institution, we've really, shut down the operating rooms. We're only doing urgent or emergent cases. And I think that's probably most people's experiences. I'm sure we will see a time when our operative volume goes up significantly once it's safe to operate again. Lastly, what about your inpatient care volume? How much impact has COVID had on the inpatients that you're caring for? Yeah, still some people coming in, but Seems like big decreases in volume, which is consistent with what we're seeing here. Okay, great. I wanted to get some of that information because, you know, the whole reason that we're trying to do this series is because of the impact on education. And to that end, I'm just gonna really quickly call attention to a survey that we've posted on our website. This is a urology group out of Italy who is collecting some information on online education for urology residents. It's being led by one of the chief residents in Florence. So if you have 3 minutes to spare, click on the survey link and do the 3-minute survey and give them some data about how your education's been impacted by COVID. All right, getting to the meat of things. So like I said, I'm going to try to make this a guidelines-based talk. There are 2 AUA guidelines, the male urethral stricture guidelines and the urotrauma guidelines that both have some specifics on pelvic fracture urethral injuries. And there's also an SIU ICUD consultation on pelvic fracture urethral injuries. So that's a useful source of information as well. I'm going to try to call out the guidelines. They'll be in orange, and I have a kind of at the bottom, I'll point out which guideline it comes from, just so you know. And this is definitely something that's testable, so it's really good to review it. All right, our first question related to our pelvic fracture urethral injuries. Where does the injury to the urethra usually occur in pelvic fracture urethral injuries? Is it the penile urethra, the penobulbar junction, the bulbar urethra, bulbomembranous junction, membranous urethra, prostatic urethra, bladder neck? Okay, great. So it looks like about 2/3 of people are saying the bulbomembranous junction. And that's right. Most of the time, injuries occur at the bulbomembranous junction. And I think this is the best picture I could find to really show why this happens. So I think there's 2 keys, which is there are attachments here to the pubic bone. And if you see, this is the puboprostatic ligament right here, and this is attaching the prostate to the pubic bone. And then there is also the perineal membrane, which has some attachments to the pubic bone as well. And so that really anchors the urethra in place to this bony landmark. And so as a result, when you have pelvic injuries and usually have you know, shearing injuries to the urethra, the disruption and the injury usually happens right here at the junction between the membranous urethra, which sits at the perineal membrane, and the bulbar urethra. So that's usually the place that is injured. That said, in children, sometimes that's different. The injury can be more proximal because the prostate is more underdeveloped. I put up this staging system just to remind myself to mention that there are a few staging systems that exist, that AAST has one, EAU has one. They are honestly not widely used. I think the most important thing that people like to distinguish when they're evaluating urethral injuries is it a partial disruption or a complete disruption? And in a partial disruption, you usually, on performing a retrograde urethrogram, will see contrast going into the bladder. Whereas with a complete disruption, usually no contrast will get into the bladder. You know, I think that's nobody, I think, really widely uses these grading systems, but it's good to know that they exist. So the classic sign of urethral injury is blood at the meatus, and often patients will have a distended bladder. They won't be able to void. You may see a scrotal or perineal butterfly hematoma. It's described that, you know, on DRE you can feel a high riding prostate. I have never felt this, but you know, it's definitely a buzzword to look out for if you're taking an exam. And really just remember that you should have a suspicion for urethral injury in patients with pelvic fracture, and particularly with fractures of the pelvic ring, and we'll talk a little bit more about that. Remember that you know, you should perform a retrograde urethrogram in patients with blood at the meatus after pelvic trauma, and that's really important to make the diagnosis. So this is a 35-year-old man who is involved in a motor vehicle accident. He had pelvic fractures and blood at the meatus, and this is a retrograde urethrogram that was performed. And you can see here in the first picture, you see the contrast going into the bulbar urethra. I will note he had a CT scan with contrast before he had this rug done. So he does have contrast in the bladder. That's not from his rug, but it's actually from his previous contrast that he received with a CT scan. And then you can see here, there's more extravasation of this contrast, and this contrast is not getting into the proximal portion of his urethra here. So this is a complete disruption. So the next question is, if you saw this retrograde urethrogram, what would be your next step? Do you try to place a catheter, give it one attempt? Do you place a suprapubic tube? Do you go for urethral realignment? Or do you take this patient to the operating room and explore and try to repair this? So it looks like some people would try to place a catheter. There's some people who would try to realign. Only a few people are going for surgical exploration, and most people are advocating for placement of a suprapubic tube. Great, so we're gonna go through this a little bit, thinking about the acute management for pelvic fracture urethral injuries. I think one thing to remember is that these patients often have concomitant injuries, and so the acute management will really also depend on how hemodynamically stable and what other injuries they have. About 90% of patients with pelvic fracture urethral injuries have other injuries that need to be managed as well. So a single attempt at catheter placement, this is definitely something that's feasible. There's this concern, which is there's not necessarily data about saying that maybe you could convert a partial injury to a complete injury. But like I said, I don't think there's any data to truly support that. In partial injuries, a catheter is able to pass in about 50% of the time based on data. So it isn't unreasonable to try a single attempt at a catheter placement. I would say if you do a retrograde urethrogram and you see that it's a complete distraction, you probably are just you're not going to try to place a catheter. But if you see a partial injury, maybe it's worth it. You can try one pass of a catheter, and if it doesn't go, if you're not getting yellow urine out, if it's not draining, then you're going to remove that catheter and do something else instead. Primary surgical repair, this was first described by Hugh Hampton Young in 1929, and the goal was to evacuate the pelvic hematoma and repair the urethra. These surgeries had, high blood loss, high morbidity, high complication rates without good outcomes, stricture formed in about 50% of them, high rates of urinary incontinence and erectile dysfunction. But, just for historic sake, this was from publication again in 1929 in the Journal of Urology by Hugh Hampton Young, who was talking about, repair of these traumatic urethral injuries. And here's some pictures from the article. You can see on the left here, you have the distended bladder, this hematoma that's at the site of the distraction injury, and then the remainder of the urethra. And here on the right, the distal end of the urethra here, the proximal end of the urethra here, and he's showing how he completed an anastomosis and repaired it. So pretty cool historic context. These days, we really don't do acute surgical management unless there are other concomitant injuries like a rectal injury or a bladder neck injury. And we worry that in those cases, there is a high risk of fistula formation, and it's worth it to go in and repair it right away. So really what we do and what the guidelines recommend are just establishing prompt urinary drainage. And for the most part, that's going to mean a suprapubic tube. Like I said, maybe you make one attempt at a catheter placement, but really what you want to do is just get the bladder drained and place a suprapubic tube. And these patients, they do have other injuries. And so usually they're going to need to be, stabilized from all of those other injuries. And the fastest and best way to get urinary drainage is placing a suprapubic tube. Now, endoscopic realignment is something that is talked about a lot. There's a lot of argument and discussion about whether or not we should do primary endoscopic urethral realignment. I would say if you do place a suprapubic tube and you're planning to do urethral realignment later, it really helps to place a counsel tip catheter because that helps you establish your access into the bladder later. So I'm going to go through just a little bit of this kind of debate on primary endoscopic urethral realignment. Like I said, there are really kind of two camps. One group who advocates for primary realignment There are data that show that it can increase the success of future endoscopic management. So if you think that you're kind of helping the patient down the line to have more likely, success from a urethrotomy and not have to go through a urethroplasty, then that's a reason to do it. There's the chance that you could avoid open reconstruction, and that's because there are some patients who just get realigned and need no further interventions. And then, like I mentioned, there are some who will have success at endoscopic management. Even if they end up needing a urethroplasty in the future, people will advocate for having better alignment of those proximal and distal segments, and so that makes your surgery easier. It makes it so that you can easily identify those segments, and perhaps that you're less likely to perform those ancillary maneuvers that you might have to do in a urethroplasty. There's also some controversy about whether, it's some orthopedic surgeons will try to ask for primary realignment because they want the suprapubic tube out of the field of orthopedic hardware, like especially if they're plating a pelvis. And so sometimes it can be useful in that context. The people who kind of advocate against urethral realignment say that, most of these patients are going to have a urethroplasty anyway, so it's an unnecessary procedure. The chance that it works on its own is very low. These patients may then subsequently undergo multiple endoscopic procedures because since the urethra is aligned, people try endoscopic procedures, and this may result in a longer time to stricture and delays definitive reconstruction. There's also data that shows that if you do realignment, there's no difference in the long run in terms of their rates of urinary incontinence and erectile dysfunction. And like I said, there's a lot of debate on this. There are a lot of studies. They're mostly small, cohort studies that are published retrospectively out of institutions. I've cited some of those studies down below, and I think I put a slide at the end, which should be on the website, that kind of talks in more detail about the data on this. But I would say, there's not a definitive study that really tells us. Luckily, the Turns Network they are currently running a prospective multi-institutional cohort study, and this is really to try to answer this question of urethral realignment versus suprapubic tube. So hopefully we'll have an answer after this study's done, or at least a better answer. So in terms of primary endoscopic urethral realignment, what do the guidelines say? The guidelines give an option for it. So they say clinicians can perform it in hemodynamically stable patients with these PFUIs, and that they should not perform prolonged attempts. So I think a few important things from that. Number one, these should be patients who are stable. So this is not the time to do it on a crashing patient in the trauma bay. And at Harborview, when I was there as a fellow, we often did urethral realignments in most patients with pelvic fracture urethral injuries. And we would typically wait until the patient was stable so we could bring them to the operating room where we had our cystoscopic equipment, we had fluoroscopy. Often we would do it in the context of them coming to the operating room for another reason. Perhaps they were going with orthopedic surgery for fixation of their pelvis. And then another important thing is really not to do any prolonged attempts. So if after 20 to 30 minutes you're not able to realign, then you should not continue endeavoring to get this done. You just risk, having the irrigation fluid kind of extravasate into the space. And so, making sure that you kind of set a timer for yourself. And if you can't get it, you just leave the suprapubic tube. And I put a link in here, and it should have been in the pre-reading materials as well, to a video that we made when I was a fellow that kind of talks you step by step on how to do primary realignment. So I'm interested to know, of those of you who are listening, how many of you perform endoscopic alignment at your institution? Is it kind of a standard where you do it in most cases? Do you never do it? Do you sometimes do it depending on who's staffing the case or, what the injury is? Okay, so looks like maybe about a third of people never do it. About 40% sometimes, depends on the attending. And maybe about 10 to 15% do it in most cases. Okay, great. So for those of you who never do it, I'll just briefly kind of take you through the process. this is what the setup looks like. And like I said, you know, we always would do it in the operating room where you have 2 towers, you have 2 scopes, you have your renal dilators, which you use to get suprapubic access. And you do want 2 people there to help perform it. You know, this is definitely a 2-person job. And you have a scope going suprapubically and another scope going through the urethra. Fluoroscopy is really helpful, and you know, this can help you make sure that your scopes are aligned. And you can see on the left, this is an AP view where you can see the scope from above and the scope from below are in alignment. And then you also want to get an oblique view, and you kind of go back and forth between the AP and the oblique views until it looks like you're kind of aligned in both positions. And that can really help you to make sure you're in the right space. Okay, I'm gonna see if this works. This is just a small clip from the video that I referenced that shows kind of the moment where these scopes are coming, one from the suprapubic side and one from the urethral side. So let's see.
We are looking at the view from the urethral scope, which maintains its light source throughout the procedure. The scope is advanced to the site of injury and then waits there while the other scope turns off its light and seeks the light of this scope. We see the suprapubic scope come into view. A wire is then passed through the urethral scope and into the suprapubic scope.
Okay, so you can kind of see then how you basically get a wire all the way across, and you can take that wire and put a counsel tip catheter into the urethra over that wire, and that allows you to be able to remove the suprapubic tube. So I do want to just spend one slide talking about cost effectiveness, because there was a study out of Vanderbilt done that basically tried to answer the question of, well, how should we be managing these pelvic fracture urethral injuries from a cost standpoint? And the first question they asked was, you know, should we be attempting primary urethral realignment versus just placing a suprapubic tube? And in all of the iterations they did, primary realignment was preferred as more cost effective. And I think that makes sense. You know, if you place a suprapubic tube, you know you're buying yourself a urethroplasty down the road. Whereas if you do primary realignment, first of all, there's a chance that you don't need to do anything afterwards. That's a very low chance, but it exists. And then there's also a chance that you might be able to manage them endoscopically successfully. Then they looked at, you know, how many, you know, in terms of after primary realignment, do you go straight to urethroplasty versus, you know, do you do a urethrotomy, and if so, how many? And what they found was the least costly was doing a single attempt at a DVIU, and if that doesn't work, then doing a urethroplasty. And they found that the increased cost effectiveness ratio of adding on subsequent DVIUs just increased the price by a lot. So really, by their analysis, you should only do a single DVIU, no more than that. And if that didn't work, do a urethroplasty. Now, one really important thing to notice on this is that the likelihood of success of that DVIU really determines if this is still cost effective. And if the chance of a successful DVIU is less than 32%, then the cost effectiveness analysis would favor immediate urethroplasty. And so I would say, you know, in most cases of these, especially incomplete injuries, a chance of a DVIU being successful is going to be much less than 30%. And so that's why in most cases, people are going to go straight to, immediate urethroplasty. So what do the guidelines say about this? They advocate for delayed urethroplasty. And specifically, they make a point that you should avoid repeated endoscopic maneuvers. So, you know, if you think that there's a chance of an endoscopic, like one endoscopic incision being successful, you can try that, but you certainly shouldn't try more than one, because we know that the chance of long-term success in that scenario is very low. And, I think even in studies that show higher success rates for that single urethrotomy, remember that these are patients who are highly selected. So these are not just all comers. These are patients who you think you might have a chance of success at a urethrotomy. And we know that, going through multiple endoscopic procedures can delay time to definitive reconstruction. So that adds a lot of morbidity for the patients. And often the fastest and kind of surest way to fixing it is just going straight to a urethroplasty. All right, so talking about urethroplasty, one important thing is that You know, like I said, from the kind of acute management where Hugh Hampton Young was presenting on his experience of managing these acutely, we really do wait and do these repairs in a delayed fashion, and that's because we see better outcomes with them. And so the guidelines say that you should wait until all of their other injuries are stabilized and the patients can be safely positioned before you do a urethroplasty for pelvic fracture urethral injuries. And I would say most people say, you know, this means waiting about 3 months, and it could be longer depending on the patient's injuries. I saw a small case-based series that looked at operating earlier at 3 to 6 weeks, but, you know, and reported no difference in outcomes. This was a very small series, and I think also probably represents highly selected patients. So really important and guidelines-based is that preoperatively these patients need a retrograde urethrogram and avoiding cystourethrogram. And I really liked these pictures to kind of show the importance of this. So if you see this antegrade and retrograde right here, you can see, you know, the retrograde filling the urethra up to the bulb, and then the antegrade, you can see that the contrast, you know, goes all the way down here to the other end of the urethral segment. And I think that avoiding cystourethrogram is really important in order to see the posterior urethra and where it's located. Some people will also do retrograde and antegrade cystoscopy, and the guidelines allow for that. Before surgery, you know, urinalysis, urine culture, and then often if these patients have suprapubic tubes, I'll give them a broader antibiotic, something like ceftriaxone. And then really importantly, you need to evaluate the ability of these patients to be positioned in lithotomy. And remember, these are often patients who have had really severe pelvic injuries. And so you need to make sure those pelvic injuries have been treated and they're able to, you know, get safely into lithotomy position to be positioned for surgery. So in terms of surgical technique, you know, transperineal one-stage surgery is really the gold standard. And this means excising any of the scar tissue and then spatulating an end-to-end anastomosis. And there are sometimes these kind of ancillary maneuvers that are required. And there was a nice Terns paper that was published last year that looked at the likelihood of needing to do this. And they found that in about a third of cases, these ancillary maneuvers were needed. So curl splitting, inferior pubectomy, or supracurl rerouting, and we'll talk about those. And then really rarely you needed an abdominoperineal approach. Most of these can really be done through the perineum. So this picture I think is really nice. It shows you exactly what we're doing in surgery. Here's the proximal end of the urethra, which, you know, the scar has been cut away. It's nice and open. Here's the distal end of the urethra. And importantly, you know, you need to mobilize this end. This is where you get a lot of length so that the anastomosis is not on tension. Here in this picture, you can see that they've done curl splitting. So these are the curl bodies here, and there is a midline here, and I just use a bovie to actually split. And by separating the curl bodies, you actually can make a groove where the urethra can then sit, and it kind of decreases the length that the urethra has to traverse to get to the proximal segment. Similarly, you know, the other idea is that once you've split the crura, you can then actually take out a portion of the inferior pubic bone right here. And, you know, this you just use an osteotome and you can carve out a little wedge shape here. And again, that decreases the distance that the urethra from up here, that distal segment, has to go to get to the proximal segment down here. And then lastly, which I would say is pretty rare that we need to do this, is supracurl rerouting. So in that case, what you do is you basically make a window under one of the curl bodies and you can route the urethra under the curl body. So instead of having to go over the crura, you take advantage of that kind of shorter distance. And that can be a third ancillary maneuver that you can use. And then here you can just see that, you know, they're doing a spatulated anastomosis. So post-operatively, usually the catheter is left for 4 weeks, and patients get avoiding cystourethrogram at the time of catheter removal. Most people will follow up with these patients with uroflow and cystoscopy at 3 and 12 months. And the success rates for this surgery are really good. So, you know, 90 to 95% success rates, and this is in many, many series. Of those that fail, so they have a stricture recurrence, at least half, and in some series more than that, are amenable to just a single endoscopic procedure. And usually I would say that's an incision. So, you know, in terms of long-term success for stricture-free rates, this operation is really very successful. I do think it's important to also think about some of the longer term quality of life outcomes. The chance of incontinence is actually low, so it's about 3 to 5% depending on the series you look at. And the reason for this is that, you know, males have a bladder neck mechanism for a sphincter, and usually that is not injured. So even if there's injury to the membranous urethra, which there usually is in these injuries, they still maintain continence because of that proximal bladder neck sphincter mechanism. Now, obviously, if they have a bladder neck injury or, you know, they've had bladder neck surgery in the past, that might be different. But for the most part, the chance of incontinence is quite low. And then, you know, the chance of erectile dysfunction is fairly significant, and, you know, 30 to 40% depending on the series. And so I'm just going to spend a minute talking about erectile dysfunction. There's been a lot of studies trying to understand, you know, are these rates of erectile dysfunction really just because of pelvic fractures, or are they specifically related to the pelvic fracture urethral injuries? And rates of ED after a pelvic fracture range from about 5 to 20%. And studies that have looked at this, and you can imagine that this probably depends also on the severity of the pelvic fractures. Rates of erectile dysfunction associated with pelvic fracture urethral injuries specifically are a little bit higher, 40 to 60%. I did see one recent meta-analysis that showed a 30% rate. So, you know, probably these pelvic fracture urethral injuries are also associated with more severe pelvic fractures, but there can also be something about the urethral injury itself that actually predisposes to erectile dysfunction. And the etiology has been kind of hypothesized as damage to the nervous supply of the penis, arterial insufficiency, or veno-occlusive dysfunction. And I will say that in studies that have used validated patient-reported outcome measures, about half of these patients have severe ED. So these are not patients who just have some mild ED. You know, many of these patients really do have severe ED. And there have been a few multivariable analyses that have looked at, you know, what is it that increases the risk for severity of ED. And a few things have been identified in various analyses, and these are pubic diastasis, so the amount of, if there is pubic diastasis, and then the amount, lateral prostatic displacement, and also a long urethral gap. So all of these things have been shown to worsen erectile function. I do want to also make a mention of children. One of the largest series is by Dr. McInich out of UCSF, and he published his experience with blunt pediatric urethral trauma over 32 years. And in that time period, he had 8 anterior and 18 posterior strictures, and those posterior ones are the pelvic fracture urethral injuries. And he reported his outcomes with a mean of 3 years of follow-up. And the majority of these were an anastomotic repair for the anterior strictures. If they were longer, then they got a ventral buccal graft. Looking just at his pelvic fracture urethral injuries, his outcomes were 90% success rate of being stricture-free at that 3-year follow-up mean. And so you can see this is really equivalent to what we're seeing in the adults population. We did then go back and look at the very long-term outcome of these series to try to understand, okay, if these injuries happened in children, what are their chances of having problems way down the road later in life? And we were able to contact 15 patients with a mean follow-up of 18 years. And in that time, one had gone on a subsequent endoscopic intervention. I think it was a dilation, but no one else had. So that's really speaks to the success of these surgeries. 8 of these patients had pelvic fracture urethral injuries, and the mean follow-up of those patients was 20 years. So this is really long-term data. And then you can see I just put up a table. These posterior patients, these 8 are the pelvic fracture urethral injuries. And you can see that, you know, based on their shim, their urethral symptom score, a stricture symptom score, their erectile function, and their overall quality of life, these numbers are all really high. So these patients, you know, even in the very long term, had very good outcomes. Lastly, I also want to mention female pelvic fracture urethral injuries. Obviously, everything we've been talking about so far is, all of the male anatomy. I'm certainly not an expert in female pelvic fracture urethral injuries, but that said, anyone who treats these and does trauma will see these from time to time. There's a really nice series, a systematic review that was published in BJUI in 2017, which is where I draw this from, that kind of does a nice job of detailing the epidemiology and etiology and pathophysiology and outcomes. And I just put this up. They look at different repair types and then also the various outcomes. So stricture or fistula formation, de novo incontinence, vaginal stenosis, or the patient ultimately getting a urinary diversion. And there were some of these female urethral injury patients that got primary realignment, about 11% in the review. A little under half got a primary anastomotic repair. So that's, going in right at the time of, injury and trying to repair these urethral injuries. And then about half had a delayed repair. And I think it is interesting, in the male literature, we really talk about a delayed repair because we know that the outcomes are much better. But in the female literature, this really may be different. And particularly, I think if you look at the risk of de novo incontinence and vaginal stenosis and even the rates of urinary diversion, these are small numbers, but delayed repair may have worse morbidity and worse outcomes. So, it may be that these injuries are more likely to have better success rates when repaired primarily. And I think often this is in the context of vaginal injuries. And so, it is important to avoid fistulas to think about whether we should repair these early. So I want to leave time for questions. And so I'll end with some take-home points. Remember, think about urethral injury in the context of pelvic fractures. And actually, I just realized some of my slides on pelvic fractures I think got left out, but hopefully they're in the slides online. So you can see, some of the injuries where we know that you're at higher risk of having a pelvic fracture urethral injury is with pubic symphysis diastasis and also inferior displaced fractures of the inferior pubic ramus. Those two types of fractures certainly do increase your risk of a urethral injury. And then, the highest chance of urethral injury is with these ring fractures. So that means that you have disruption of the pelvic ring. So you have a fracture somewhere on the anterior portion, if it's the pubic symphysis or in the pubic ramus. And then you also have a fracture at the sacroiliac joint. And that really makes for an unstable pelvis. And about 25% of patients with those ring fractures will have associated urethral injuries. So you can look for more data in the slides online. And remember that, usually these injuries do happen at the bulbomembranous junction. Get a retrograde urethrogram for diagnosis. This is really important to make the diagnosis. And remember that the most important part of acute management is just prompt urinary drainage. So if that's one attempt at a catheter versus just going straight to a suprapubic tube, really the most important thing is getting the urine drained. And then once the patient is stable, you can consider urethral realignment. If you do it in your practice, or if you think that it might improve outcomes. And I do have a slide also online that I think goes into a little bit more of the data if you're interested in that. Definitive management for these injuries is delayed anastomotic urethroplasty, and this is done usually at about 3 months afterwards. The long-term outcomes in terms of stricture-free rates is excellent, 90 to 95%, but do remember that the concomitant burden of erectile dysfunction is significant, and so you do need to assess for erectile dysfunction and think about ways to help patients manage this. So please remember to fill out surveys. These surveys are really helpful for us because they're allowing us ways to make sure that we can improve the series where necessary. It also gives lecturers feedback on their lectures. So thank you for filling those out. Even if you watch this later, you can fill out a survey online. And with that, I'm happy to take any questions.
All right, good morning. My name is Nnena Mmonu. I'm currently reconstruction fellow here at UCSF, and so we'll get started with some questions for Dr. Hampson. So several questions were posed relating to primary realignment. A common question that came up is, if you're able to place a catheter or perform realignment, do you usually place a suprapubic tube at some point as well?
Yeah, great question. So typically, if you are able to realign and get a urethral catheter in, we would remove the suprapubic tube at that time. Later on, you may need to replace a catheter because, the chance of them having a stricture is high. So, there's different ways to manage that. Some people will just say, well, I'm going to leave the suprapubic tube in because I know that they may need it in the future. Other people will remove the suprapubic tube, especially if you're worried about, the orthopedic hardware and not wanting to contaminate that. And then replace it only if after you remove the catheter, if they end up needing to have another way of diversion. So I would say it's practitioner dependent. At Harborview, when I was there and we did a lot of urethral realignment, we would typically remove the suprapubic tube so that patients wouldn't have to, worry about having two different catheters, which can, be morbid. They would have the urethral catheter in, and then once that urethral catheter came out, we would monitor them for development of, recurrence of stricture. And if that happened, then they would get a suprapubic tube placed at that time.
Okay, great. And then to tag along to that, how long would you leave the urethral Foley catheter in place?
Yeah, usually it's left in 4 to 6 weeks. And again, it's probably practitioner dependent. I think another important thing is you have to think about it in the context of their other injuries. So, often some of these patients are hospitalized for a long period of time. They're immobilized for a long period of time because of their other injuries. So obviously, you have to kind of think about that as well. But usually about 4 to 6 weeks, the catheter is left in and then it's removed. And at the time of removal, it is good to do an X-ray study, again, to see if the injury has healed, because obviously if there's still extravasation, then you're not going to want to remove the catheter at that time.
Okay. And then still on the same topic of realignment, what type and size of catheter would you recommend using for realignment?
Yeah, so a council tip catheter, just because remember when you're doing the realignment, you're basically getting a wire across. And so you want to utilize that to place the catheter. And, 16, we standardly use just a 16 French catheter, and that's the catheter that's left in place afterwards.
Okay. In talking about staging the patient, you'd mentioned getting a retrograde urethrogram, which is critical to sort of understand what's going on. A question that came up is, would you also potentially obtain a VCUG as well?
Yes, I think obtaining a VCUG is essential. So I think I showed that picture of, just the VCUG really helps you to see how much of the posterior urethra is present, where it's located, so that you can really tell the distraction between the two segments. So if you get the voiding cystic urethrogram and the retrograde urethrogram, you really have a much better idea of seeing where those two segments are, how much distance is in between them, so you can anticipate when you go in for surgery, both where to find them and how much distraction there's going to be between the two segments.
Great. And then thinking about patients with partial injuries, would you potentially do this blindly or with cystoscopy? Do you potentially think there's a use to doing this with the cystoscope?
Sorry, Nnena, I lost you for a minute. You said in patients with partial injuries.
Right. Sorry. So in patients with partial injuries, and let's say that we're doing a single attempt catheter placement, would you recommend doing this blindly? Is there any utility to doing this with a cystoscope?
Yeah, you could do it either way. So I think, the question is always, well, you do a retrograde urethrogram, the patient's in the trauma bay, they need a catheter. Can you just try to place a catheter blindly? I think it probably varies from person to person, but many people will say, well, try to make one attempt by somebody experienced at placing a catheter and see if it goes. If it doesn't, then stop. Others will say, I worry about forming a complete transection from a partial injury. And so in that case, don't try a catheter placement, or if you do it with a scope. So I would say there's not data that really shows us how often partial injuries are then transformed into complete injuries by catheter placement. So we don't really have data to go on, but many times people will just attempt a single pass at a catheter placement blindly to see if it goes.
Got it. And thoughts with primary alignment. In the lecture, you had mentioned doing primary alignment with a cystoscope through the urethra and also through the suprapubic tube tract. A question came up, would you potentially do it only using a cystoscope through the urethra with the wire and fluoroscopy?
Yeah, I mean, you can. I would say you want to load the boat if you're doing this, and it's really much easier to do it with a scope both from above and below. For any of you who have done this before, you know that, while you think you should know where the other segment is, you really don't, because once that urethra with, especially with complete distraction injuries, once the urethra is separated, it's really in a totally different plane. Each segment is in a different plane. And so it really does help to have both scopes, one from above and one from below. And the key, and you can see this if you watch the video, I think the key is really that you're using the light from one scope to help guide you. So at the point when you use fluoroscopy and you get both of the scopes aligned, what you'll do is you'll actually turn off the light of one scope, and then the other scope will try to find the light of the other one. And that's really, I think, has helped to be successful in urethral realignment, is to use that light to kind of guide you to where you need to be. And once you find both scopes, then you can easily pass a wire between the two scopes and really know that you're getting that wire all the way through and through.
Got it. Okay. Specifically on the repair for pelvic floor urethral injury, urethroplasty, one question came up. I think during the lecture, you'd mentioned several approaches for getting sort of attention-free anastomosis. One question came up is, how would you approach an injury that involves too much injured tissue and cannot be anastomosed in a tension-free manner?
Sorry, repeat the last part of that question again. In a urethroplasty.
Right. So an injury that involves too much injured tissue and cannot be anastomosed in a tension-free manner.
Okay, yeah. So, I talked about those ancillary maneuvers. I would say, and based on the turns data, about a third of the time those were needed. But honestly, most of the time it's really just about mobilizing that distal urethral segment. There's a lot of laxity in that bulbar urethra, and by dissecting out the distal segment, you can get a lot of length. And so, in almost all cases, even if you can't get enough length by just mobilizing the distal urethra, by using those other ancillary maneuvers, you're going to be able to get things to reach without tension. So I think, almost every time you're able to get those two segments. And typically I'll say with these injuries, there is not a significant amount of scar tissue on each end of the transected segments. So it's not like you're losing a lot of length on the urethra. And so that's why you're able to be successful in getting these two back together. Often the problem is that these segments are malaligned because of the distraction and the injury. And so you basically, you may have to kind of go through and cut these segments out of the scar tissue that's formed in order to get them in realignment. But often it's not that you have a significant length of stricture of the urethra. So you have not necessarily lost a lot of length in the urethra from the injury itself, which is why you can be successful in anastomosing them primarily.
Great. And I think probably time for one more question. This question is about identifying the proximal urethra in the repair. Whether you recommend using a cystoscope dilator to cut down intraoperatively.
Yeah, great question. So, it's really key to have access to the proximal segment because it can be difficult to find it. That's why some people advocate for realignment, because they think it's easier to find those proximal segments if the urethra has been realigned. But two things you can do. One is just using a sound. So you put that sound, the curved sound, you put it right into the suprapubic tract. and then you can feel that as it goes into the bladder neck. And using that can be really helpful because then from the perineum, you can actually feel the tip of that sound and cut onto that in order to find the proximal segment of the urethra. Some people do use cystoscopes to do that instead, but I would say probably most people find that using a sound works just fine, and you're able to identify that proximal segment and know where it is, so that you can open it up, find the lumen, and then spatulate it to create your anastomosis.
Great, thank you. And with that, I think we may be out of time. Just a reminder that the questions will be on the website that were not answered during the webinar.
Okay, awesome. Well, thanks everyone for participating. I'm happy to answer all of the questions offline and post them, and hopefully my slides are up as well. I just, again, want to say thank you to everyone for tuning in and making this such a successful series, and we really want to try to continue it into the future. And please make sure that you're all staying safe, you're social distancing, wearing masks, and keeping yourselves safe so that we can continue to take care of patients as well. So thanks, and have a great rest of your week.